seconds and then start your speech.
Yeah.
You can go live now.
Good evening, everyone, and welcome to today's webinar on what's new in flu, current challenges and management options. For this webinar, today we have with us Dr. Pramod Jog. Dr. Pramod Jog is a pediatrician and neonatologist from Pune, and Dr. Pramod Jog has an experience of 38 years in this field. Dr. Pramod Jog is a professor of pediatrics at Dr. D.Y. Patil Medical College, Pune, and also the ex-president of Indian Academy of Pediatrics in 2016. He was an ex-standing committee member of International Association and ex-member of Gavi. Dr. Pramod Jog practices at Jog Children's Clinic in Pune, and he completed his MD Pediatrics from Vijay Medical College in 1985 and MBBS from Vijay Medical College in 1981. With this introduction, I request Dr. Pramod Jog to start our webinar today.
Okay, thank you, Dr. Manohar. I will definitely, come directly to the point because we are going to discuss about an important topic, and that is related to flu. And the topic for the day is what is new in flu. By the way, are you able to see the slides or?
No, sir, not.
Okay, I will just share my screen. Now, can you see?
Yes, but we need to go on full screen.
Okay, I hope now it will be better, right? Okay.
Yeah, sir, it's okay now.
Thank you. So I assume that I am with my friends in Kolkata, and when we discuss what's new in flu and challenges in dealing with influenza, you can understand that the nomenclature of the flu virus is something like my nomenclature. So it is like Z, that stands for Zog, from Pune, and the month of birth and the year of birth, and then the short form of my name PP, that's Pramod Prabhakar. So this is the nomenclature, which includes the origin of the strain, the city, the year, and so on and so forth. And incidentally, I was also the IAP presidential strain of 2016. Okay. And when we discuss flu, actually, I am reminded of a case which recently came. And he was, I will tell you, a 3-year-old boy. And he came with breathlessness, fever, and cough. And when I examined this particular child, his blood gases were not normal. And the X-ray was showing ARDS. Okay. And he was admitted to the PICU. He was ventilated. Then he received Oseltamivir, supportive treatment, and the throat swab showed H1N1 positive. And many of our colleagues then, they started discussing whether Oseltamivir could have been started very early and not when the child was already in the ICU. He was a previously healthy child and simply presented with cough, cold, and fever. And the progression took place over 3 days. And whether this progression could have been prevented, and whether every child with cough, cold, and fever could be given Oseltamivir upfront, particularly in the flu season. And that was the discussion. And that's prompted me, to take up today's discussion. And, I will discuss about some of these facts in details in the course of my talk. And also, I got another, case at other extreme. And, this child was not very sick, a usual girl, 5-6-year-old, and came into the clinic with a small little doll in the hand. And while I was about to examine this girl with mild fever, cold, and cough, the girl started speaking to the doll, saying that, don't worry, it's viral, you will be all right, And I was surprised to see the commonness of this term viral. And for so many years, we have been listening to this term viral. And, these days, of course, when someone says it's viral, many times I am really, really worried because I don't know whether it is going to be COVID, whether it's going to be H3N2, whether it's going to be adenovirus, which is likely to take a little longer time, whether it's respiratory syncytial virus, or whether it is human metapneumovirus, or whether it is plain simple rhinovirus. So there are many, many connotations to this term viral. And over last few months, what we are witnessing in the post-COVID period is waves of different viruses. Okay, Of course, we have witnessed pandemics, right? From 2009, we have had H1N1 pandemic. Then we had MERS pandemic, though not affecting our country. And then after this COVID, little bit under control from the last June, we had that HFMD, that, hand, foot, mouth disease. Later on, I got many cases of respiratory syncytial virus. In between, there were cases of H1N1. And then came the era of that adenovirus. And then recently we have this H3N2, which is of course a type of influenza A again. And many parents ask me, sir, what is this? Why after COVID we are getting patients like in so many surges? And I always keep telling them, my dear, the COVID had made every one of us sit inside the house. Children were inside, parents were inside, and not a single virus got an opportunity to attack children. And that's why now when children have started going out of the house and started going to the school, these viruses against which these children never had any immunity over the last 2-3 years, now these viruses have started playing their role and they're attacking children. And when one child transmits it to other, then it is an infection which spreads like anything. And this spread from one child to other, in medical terms, we call it as RO. That is, how many children does one child infect? Okay. And this RO, as we all know, for COVID is quite high. And in fact, for influenza also, it's high. During this particular season, I also saw quite a few older children getting affected. And what I witnessed in last 1 year is that children are coming with recurrent respiratory infections. So the mother will come on the first of the month, then she comes with fever, cough and cold. I give her some medicines. The child is fine for the next 4 or 5 days. Again, after about 10 days, the mother is present in my OPD. Again, after 10 days, the same parents are again climbing the staircase of my hospital. And these are recurrent infections. And what I can see is the frequency is more and the interval between two infections is also less. Some of these viruses, which I just mentioned, are also producing otitis media. And some children are coming with adenoidal hypertrophy with snoring at night and mouth breathing. And as I told you, influenza usually comes in the months of monsoon, like the June and July and August and September, particularly, in most of the parts of our country. But here, during this period, it has been an unseasonal surge. We never saw influenza attacking children in February and March and April, isn't it? And then the adenovirus outbreak came with varied presentation to the tune that almost the fever would last for 7 or 8 days, and in some cases even up to 2 to 3 weeks. And it has been a prolonged illness. Okay. And because of so many viruses confusing our minds, there has been a diagnostic dilemma. Okay. The total WBC count is being affected by some of these viruses. CRP, we were under the impression that only bacteria can make the CRP high. But no, it's influenza and adenovirus and our COVID, which are, making CRP on the higher side. And the nasopharyngeal swab, I never sent so many swabs before this, particularly in the non-COVID season for these other viruses. But now, when the fever is going on for a long time, and when I really want to avoid antibiotics in a particular child and follow what is called as diagnostic stewardship, then I usually I have started sending more of nasopharyngeal swabs. And when I don't want to use antibiotics, which I call as antimicrobial or antibiotic stewardship, then I am also thinking twice whether I'm dealing with influenza, whether I really need to give the medication like Oseltamivir and so on and so forth. And also the use of inhalers and the intranasal corticosteroids also in some parts of the country has increased. So with all this background, I will just tell you the story of a few cases which came to the clinic over last 3-4 months. And one of them is Viru because he was a child with viral infection and he had fever for 3 days, cold and cough. He was on meter dose inhalers since last 4 months. He was well controlled and the symptomatic treatment was given to this child. He came back after 3 days. Again, for a day, he was half febrile and came again with fever. But in between these 2 episodes of fever, he has always been active. Okay. So these are recurrent viral infections, which I told you are more frequent and occurring at shorter intervals. And obviously, for these children, where we are getting back-to-back viral infections, we are not going to give antibiotics. So one has to be clear, and one must be able to differentiate a viral infection from a bacterial infection. It's very simple, and most of our learned audience colleagues, they know that a viral infection is generalized, and in this generalized infection, usually more than a system is involved. For example, the same child will have runny nose, the same child will have sore throat, cough, same child will have discharge from the eye, the same child will have rash, and some child will have diarrhea. Okay, while bacterial infections are localized, a child who has follicular tonsillitis won't have pneumonia. It's localized to the follicles in the, and the congestion in the throat and the follicles associated with tenderness in the cervical nodes. That is classically bacterial. And when the fever comes down in a child with viral infection, usually the child starts playing after receiving paracetamol. Fever comes down, and mother says, okay, very good. The child usually plays, he is happy, eating well and smiling when there is no fever. But in bacterial infections, when the child is given paracetamol, fever does come down, but the child is not his usual self. Even in absence of fever, he appears sick. Mother says that the fever is down, but he is not eating. Mother says that the fever is down, but the child is not smiling. He is just lying down in a corner. That is bacterial. And these are some of the clues to differentiate between viral and bacterial. And obviously, we know that if a single child in the family has flu and the sibling has fever and cough, or parents have fever and cough, we usually would put it as viral, because viral infections are there and we transmit from one to other in a very, very short time. And that's why some of these cases where the presentation is very mild and where we are more than sure that it's viral, please keep away from antibiotics and counsel the parents. Tell them, I told you the story of adenovirus where the fever can go on for 2 to 3 weeks. So usually I tell them that, see, this child has fever, follicular tonsillitis, discharge from the eye, and I call this as pharyngoconjunctival fever. And this is an adenovirus which has, changed its behavior for unknown reasons over last 2 to 3 months. And it will take 3 weeks for your child to come out of this fever. So the parents are counseled in this way. If the fever disappears in 2 weeks, obviously, they give all the compliments to me saying that, oh, your treatment made my child normal in 2 weeks. Okay. So you have to tell the parents that COVID has definitely changed some of the behaviors of the viruses. And before we start the discussion on some of the aspects of influenza, I will like you to understand as to which parts of the respiratory system are affected by viruses and bacteria. For example, if it is the rhinovirus, usually it attacks the nose. If it is tonsillopharyngitis, 70% of it is viral and 30% is because of group A beta hemolytic streptococcus. Okay. Otitis media and sinusitis are predominantly bacterial in 70% cases. Okay. And pneumonias, that majority of them still continue to be viral, and the bacteria which attack the upper respiratory tract as well as the lower respiratory tract include the pneumococcus, H. influenzae, and Moraxella catarrhalis. Okay. So you must be able to identify your enemies, because you are not going to send the nasopharyngeal swab at each and every child. So if the onset is with common cold-like symptoms, upper airway involvement, mild or very minimal fever, child is not exhausted and is playing well, then always think of either rhinovirus or influenza or parainfluenza or a respiratory syncytial virus. Okay. Along with the respiratory symptoms like cough and cold, if the fever is very high, okay, if the child has prominent headache, if the parents bring the child lifting an older child, 7, 8, 9-year-old, and with severe pain in the muscles and with extreme weakness, please suspect flu. And you are fully justified in starting antivirals like Oseltamivir when a child comes to you, when there is an epidemiological thing around. And adenoviruses, as I told you, they are the viruses which are predominantly respiratory, but their non-respiratory presentations are also seen. And one of our examiners, I remember, he used to ask us, which is the only respiratory virus which comes with more of non-respiratory presentations sometimes. And that is adenovirus, which can come with mesenteric rhinitis, we can come with hemorrhagic cystitis, and then diarrhea. So adenovirus is a different ballgame. It can also produce pneumonias, and it can also sometimes produce pleural effusions. So Remember, adenovirus over last few months has started behaving differently, and fever doesn't come down in 3 or 4 or 5 days, but it's taking on an average 7 or 8 days. And in an infant who is under the age of 1 year, we are always seen respiratory syncytial virus producing bronchiolitis. Okay, and if the fever is associated with dry cough, more of lower respiratory symptom, then we have to always remember of COVID-19, particularly if the child also has loss of taste of the sense of a smell also, and that's little older child. Okay, you have to remember that bacterial infections like streptococcus can produce fever with follicular tonsillitis and tender cervical node, and adenovirus also produces follicles on the tonsils, exudative tonsillitis, but there you won't get a tender cervical node. And adenovirus, the erythema of the pharynx will not be that great, but in streptococcal, the bacterial infections, the erythema of the throat will be very, very great. And if a child comes with fever and grunting, and the parents are really, afraid whether something wrong, then in a tachypnic child, you must think of pneumococcus. And if the child is progressing rapidly from pneumonia to pneumococcal to effusion and empyema, and the child is toxic, you have to think of staphylococcus. And in a child who is beyond 5 years with predominant cough, but little signs, then think of mycoplasma in a school-going child. So the purpose of telling you the, know your customer thing of your enemies is to identify and have an educated guess, because this is the one which is going to guide you to plan your therapy, whether antibiotics, antivirals, or nothing. And the cases which I told you I would show you is a 4-year-old child with cough and fever and high-grade fever for the last 5 days, not settling with oral medicines. The general physician had put this child on some antibiotics like amoxicillin, and on admission, you can see that this X-ray is showing a bit of infiltration on the right side. He was tachypnic and needed oxygen support. As a protocol of the hospital, we check all the parameters, and the lab parameters showed the WBC count on lower side, the platelet count on the lower side, a derangement of the liver function test to some extent, and the nasopharyngeal respiratory rate was positive for H3N2. Who are the children where we send the nasopharyngeal swabs? Those who have started showing respiratory involvement in a severer form, those who are hospitalized, and this showed H3N2. Okay, so this was a child who came with influenza with low WBC count and low platelet count. Another child, again of H3N2, but again, here the counts were normal. Again, fever going on for 5 days and fever was not settling. And another child who came with normal counts, but rise in CRP. You can see that the X-ray on the right side is again showing infiltrates, and it is H3N2. And another interesting case which came with fever, cough, cold, and status epilepticus. Okay. And in a year-old child, we usually would think of febrile convulsion and usually won't be much worried, but he came in status. And as he was admitted in the flu season, we did his nasopharyngeal swab, which showed H3N2, and the MRI showed non-specific encephalitis changes. CSF was normal, and this was a child of influenza encephalitis. Okay. And another girl, a daughter of IT sector parents. Okay. Now, these are the parents of whom I am really, really worried, because IT doesn't mean for me information technology, but it's something like inquisitive and troublesome. So they will ask many questions about influenza, and they will ask what is the classification and which is the most common group. Then I tell them that it's influenza A. Then in influenza, which is one going on, I tell them H3N2. Then what is the meaning of H and N, and so on and so forth. So it continues. And those parents with shorts and the laptop in the hand, which they bang on my table, I have to literally give half an hour. Some of them, of course, are really intelligent, and I enjoy discussing with them. But then some of them are really inquisitive and troublesome. Anyway, so this daughter of those IT sector parents, came with high fever for 3 days with throat irritation. And parents, after me to do something because the girl had exam 2 days later. But the throat was showing only mild congestion, and I just gave paracetamol. And I was in two minds whether I should send this respiratory panel for flu and the adenovirus, because, these two were very much around. But then I waited. I told them, I counseled them. I did CBC and CRP. and I restrained myself from sending the throat swab, and I also restrained myself from giving Oseltamivir because this was an older child. Okay, the throat irritation and mild congestion, I thought probably did not warrant these various things. So you have to individualize the decision. But this child, Tejas, 3-year-old boy, came for cough for almost a week and high fever for 3 days with crepitations, with lower respiratory involvement. Of course, this particular child was initially put on this coamoxiclav, and he was admitted for persistent fever, okay, because he was having illness for almost a week. And he was also put after hospitalization on intravenous coamoxiclav, and the counts were normal, CRP was normal. And as I told you, as a protocol, we sent the swab of all the hospitalized patients with respiratory infections, which showed influenza A. And then we added Oseltamivir. And of course, the discussion which went on was whether we need to stop the antibiotics. I will tell you that we could not stop the antibiotics because the reasoning that was given was that a child who has influenza, 25% of them can also have bacterial pneumonias. Okay, so remember, even if Oseltamivir has been added because of this positivity of the swab, you may not or need not discontinue the antibiotics because 25% of them have additional bacterial infections. However, these decisions are individual, and you have to take a call depending on the individual patient. But please remember to take the advantage of the laboratories and sending the nasopharyngeal swabs, provided you have these facilities. Now, today morning, the younger sib of this same child came with high fever since yesterday. And now, what do I do? Remember, I told you that the RO, that is the transmissibility of influenza, is great. One child can very well infect another few children. And whenever you get a younger sib in the same family with similar symptoms, please remember that you are fully justified in giving Oseltamivir as a prophylaxis in the SIB or any member of the family. See, there are some members in the family who are having high risk problems. And you all know that diabetes and asthma and obesity, then people on steroids, they're all high risk individuals. Even pregnancy, though not a high risk condition, it's a condition where flu can create more problems. People above 65. And that's why those who are in contact with a child with proved influenza, they need to be given prophylactic Oseltamivir. And that is why now we need to know a lot about this influenza and the KYC, that is know your customer of this influenza. So influenza, know your customer. We'll try to find out, the details, just as we are usually asked in the banks about our PAN card and Aadhaar card and so many, photo IDs and others. So let us know this virus thoroughly well. And all of us are aware that the Spanish flu, which, came as a pandemic in 1918, 1919, affected almost 500 million people. Okay, almost 1/3 of the world's population at that time, and 50 million succumbed. Okay, that was H1N1. And then in 1957, we had H2N2. Okay, and in 1968, we had H3N2. Okay, which was Hong Kong flu. And then 2009, we had our H1N1 novel influenza, swine flu. Now, the thing is that these were the 4 major pandemics till now in the world. But every year, this particular virus shows something or the other. And this is because of what is called as a shift and a drift. Shift is a major change and drift is a minor change. So, for example, if my friends from Kolkata, suppose, Pallab becomes Pramod, that's a minor change. But if Chatterjee becomes Jog, it's a major change, and that's a shift. Okay. So remember that there are changes which are either minor or major. And that is why the change of the outer protein, see, there are 2 proteins on the outer side of the influenza virus. One of them is called as H, that is hyaluronidase, and N is the neuraminidase. And H1N1, H3N2, these are the different combinations of various proteins which are there on the outer wall. And you have seen so many news items striking the newspapers which said that H3N2 virus is linked to the high fever and cough cases, and the cold wave and the rising pollution have triggered the surge in the influenza cases, and the private hospitals have started screening for flu, and number of COVID admissions rise. At the same time, flu also is rising. Whenever flu and COVID come together, we call it as a twin-demic, okay? And right now also, unfortunately, in some parts of our country, the cases of COVID have started rising. We have to be very, very careful, because it's very, very, very difficult to differentiate all these different viruses. I always tell my friends that, see, even Rajnikant cannot differentiate different viruses. I told you how to identify enemies, but it's very difficult, very difficult. And that's why you have to remember that whenever a child is brought to you after a particular period of 4 or 5 days, when he is coming to you with complications, he is about to be hospitalized or is hospitalized, please see that you take the advantage of the nasopharyngeal swab and try to establish a diagnosis. And as I told you, there has been definite surge in the cases of high-grade fever, and there has been rising pollution and temperature fluctuations, which are leading to significant rise in the flu-like symptoms. And viral infections are in full swing. And H3N2 is now in the air, and the infection in pediatric patients, as I told you, is getting dragged for a longer time. But remember, high fever with chills and a child coming with headache, along with muscle pains and weakness, please remember, in the epidemiological situation around, you are fully justified in giving Oseltamivir, okay? And remember that in the initial part of the year, ICMR network of laboratories, they had released the statements where influenza A H3N2 has been always reported to be on the higher side, okay? And there have been plenty of challenges related to the healthcare. We all know that we have to wash the hands, we have to keep a hands distance, we have to use a handkerchief, we have to cough in the elbow, which is called a Dracula cough. Okay, all these are the precautions which we discussed during COVID times, and they are very, very, very true for any infection which is spread by droplets, and influenza is one of them. So you have to be very, very careful. Okay, and remember that many studies came from different parts of our country saying that the dynamics of the occurrence of influenza in relation to the seasonal variation is always observed, and that is always more in monsoon and in the post-monsoon period. Okay. Also, the incidence of influenza and the related deaths has been increasing alarmingly. Okay. And as I told you, this is one of the most common infectious diseases, and it is highly contagious, and it can cause mild to severe illness. I'm sure, remember 2009, when we had the classification of influenza into different severities like mild, moderate, and severe, wherein we know that if the symptoms are mild, like mild cold, cough, fever, it's okay. We do not, subject this particular child for testing. But for a child who has respiratory rate which is on the higher side, or if the child worsens and goes into distress or the saturation drops down, we definitely do the testing and definitely put this child on Oseltamivir. And there have been serious outcomes of flu infection which can result in either hospitalization or death. We all are aware of the different types of influenza viruses, of which influenza A is the cause for the major pandemics all over the world. Okay, and these pandemics are because of the antigenic variation. We all know that swine flu, wherein the viruses, the H and N proteins, which were mixing, and the swine at that time acted as a mixing vessel. Okay, so there this H1N1 novel flu virus came into existence. Influenza B usually affects only humans, and that's why it doesn't create pandemics, because it doesn't affect the animals. Okay, and influenza C infects humans and the swine, but these infections generally are mild. What is going on right now is H1N1 and H3N2 and B. Okay, so remember, all these three are going on, and B has its own other types like Victoria and Yamagata, and the vaccine usually contains H1N1, H3N2, and Victoria and Yamagata lineages of type B. Okay, so as I told you, the transmission is very, very rapid, and that's why you have to be about 6 feet away from the people, and the transmission is with the droplets, and the droplets can land in the mouth or the nose of the people who are nearby, and that's why people should stay away. And most of the healthy adults may be able to infect other people one day before the symptoms, up to 7 days after becoming sick. So you do not know the chance of your contracting this flu virus. And I appeal our pediatric colleagues to wear the mask, because we have started having these kids in the OPD, and we really don't have any means to find out whether it is flu or COVID or something else. That's why please keep nice N95 mask, and please see that you take care of yourselves, because many of us who are above 65, many of us who have some comorbidities like hypertension, diabetes, obesity, or asthma, and some of us who unfortunately are on some steroids for some reason or the other, you have to be really careful. And remember that children can pass on the virus for longer than 7 days. And many times, parents usually do not know all this. They will make the child just stand in front of us, or, the child is coughing directly on the face of Dr. Jog, and, something which goes on. So please take care. And as I told you, it's extremely difficult to differentiate these influenza-like illnesses, H3N2, then severe acute respiratory infections, and COVID-19. Remember, flu, that is either H1N1 or H3N2, is the father of all those influenza-like illnesses. And as I told you, fever, pain in the muscles, and cough and weakness and sore throat are common to all. What differs is breathlessness. See, influenza and COVID, both of them are known to affect the upper as well as the lower respiratory tract. And that is why involvement of the lower respiratory tract in producing breathlessness is seen in flu as well as COVID. However, headache is something which is very common with influenza. And diarrhea, as I told you, can occur either in adenovirus and also COVID-19. We have seen children getting diarrhea during the pandemic of COVID-19. Okay. And that's why you have to be aware of the warning signs. Please tell the parents that if the child starts developing fast breathing or develops cyanosis, or if he's not drinking enough of fluids, or not interacting with you, or has become really irritable, then please see that you come immediately for some medical help. Okay. And this flu virus, though it's an upper respiratory virus to begin with, it can spread to the middle ear, producing middle ear infection. Okay. It can also go down, producing pneumonia and acute respiratory distress syndrome. And as it's very difficult to differentiate the viral pneumonias from bacterial pneumonias, antibiotics many times are given because of ignorance, because we don't know what's going on. And as I told you, nasopharyngeal swab will definitely add to what I call as diagnostic stewardship. Okay, that means we are responsible for the use of antibiotics, and the only way to differentiate a virus from bacterium today is in the form of nasopharyngeal swab. So if you have the facilities, there are different panels, and there is a panel called as expert flu, which gives this COVID with flu with RSV. Okay, so there are different panels. There is BioFire, of course, that is costly, which gives you information about different organisms, but it costs more than 10 or 12,000. So you have to just see and weigh the situation, and depending on the need, you can utilize the nasopharyngeal swabs. The point is that many times when you get those nasopharyngeal swab reports, there are some organisms, some viruses, which are also the ones which can attack the lower respiratory tract, and they correlate very well with the lower respiratory tract viruses. For example, influenza and COVID, I told you, they will affect both the upper as well as the lower respiratory systems. RSV, human metapneumovirus, influenza, parainfluenza, and adenovirus. These 5 viruses, if you get in the BioFire or the panel, then in case if the child is worsening or developing low respiratory symptoms, then they correlate very well. Okay. But remember, my dear friends, if you get adenovirus with rhinovirus, then rhinovirus is an innocent bystander. Usually rhinovirus is many times a report along with some other virus like adeno or influenza. It's, he's like a neighbor who always enjoys, the husband and the wife in the neighboring house fighting with each other. And that's why, remember that rhinovirus, if it is seen, just do not worry about it. It's a mild one. Usually in 3 to 4 days, it settles. Flu, takes little longer. Adeno takes further longer. And COVID complicates, as you know, in different ways. Okay. So remember, all these complications are known, to be more, and some of them, they worsen the existing diseases like asthma. Okay. So now let us see as to how you manage all these different cases. And remember, if the child has mild type of influenza, which we usually get in majority of the cases, there is nothing great to be done. Tell the parents to give plenty of fluids, give cough suppressants, give lozenges in an older child, antipyretics like paracetamol. And if there has been a lot of headache and muscle pain and all, you can give non-steroidal anti-inflammatory agents, but not aspirin, because we know from our knowledge that Rye syndrome is something which is common if you give aspirin in children who have influenza. Okay. And then most patients with influenza will recover in 3 days. Weakness may persist for a long time. And severe cases, of course, they need hospitalization and IV fluids and other supportive measures. The main thing is that if you suspect influenza from the symptoms that I told you, then you are fully justified in giving Oseltamivir empirically. Okay. So remember, the medication called Oseltamivir is a neuraminidase inhibitor. I told you that there is H and N. These are the proteins on the outer side of this influenza virus. And this neuraminidase is the protein, which is responsible for releasing the virion from the host cell to the other cell. Okay. And that is why this neuraminidase enzyme, which is critical in the release of those virus particles, is blocked by Oseltamivir. And that is why it is useful in the management of influenza. Remember that this Oseltamivir basically is very potent, and it's a selective inhibitor of neuraminidase enzyme of the influenza viruses A and B. Oseltamivir is a prodrug which is converted to the active form oseltamivir carboxylate in the liver, and it inhibits influenza virus replication and pathogenicity. It also prevents further spread of infection, and it is effective against all kinds of influenza A and B, including the avian H5N1, swine origin H1N1, and H9N2 strains. Okay, this is what I was trying to tell you, the mechanism of action of Oseltamivir, where you can see on the upper portion of this picture, there is a virion, and there is release of new virions, and there is a continued viral replication. However, if you see on the lower part of the picture, there is a red cross which I have put there. So from the virion, that is the virus, you cannot have the release of new virions, and that's why the virion release is blocked and the viral replication is blocked. And that's why when you give Oseltamivir, the fever simply breaks down within 24 hours. The child is really fine, and the fever comes down. Remember that you have to give Oseltamivir in the first 48 hours of illness of influenza. Okay. And this Oseltamivir was the first oral neuraminidase inhibitor, and it has been approved in more than 100 countries. Okay. And you should also be aware of the dosage and the recommendations for Oseltamivir. The dose of Oseltamivir in pediatric practice is 3 milligrams per kg. So if there is a small little child who is, say, 10 kg, okay, then the dose will be 30 milligrams. And we can very well give Oseltamivir in the syrup form. However, in an older child, okay, for example, a child who is weighing less than 15 kg, the dose comes to 60 milligrams per day. And that's why it will be very convenient to divide this dose into 2 parts, 30 milligrams in the morning, 30 in the evening. And that is why this Oseltamivir capsule, which has been recently launched, will be of great help for those kids who are less than 15 kg. For those who are above 23 kg, the dose comes to about 120 milligrams per day. That is 60 milligrams twice daily. That is 2 capsules in the morning, 2 in the evening. Okay. So this is the therapeutic dose. And that's why you can use 30 milligram capsules with a lot of convenience, and you will save a lot of money, and it will be a great convenience. Okay. Remember, the adult dose is 75 milligram capsule twice daily for therapy. But I told you earlier that there are some people who are from the high risk category. Okay. The contacts, there you have to use Oseltamivir as a part of prophylaxis, which we call as chemoprophylaxis. It has to be given for 10 days and it's given only once daily. So the same dose, which is given, twice daily, is given once daily. So example, if you are giving 30 mg twice daily for a child less than 15 kg, for prophylaxis, you have to give 30 milligrams only once daily. Okay. And the post-exposure prophylaxis, that means in children or adults who have been exposed to a patient of influenza, the prophylaxis is to be given for 10 days. Okay. And this Oseltamivir capsule, as I told you, for children under the age of, rather under the weight of 15 kg or 15 kg, the treatment dosage is for 5 days, 30 milligrams twice daily, and the prophylactic dose is 1 capsule once daily for 10 days. Okay. And as I told you that there is a lot of convenience, prevention of wastage, and also economically very, very convenient. Okay. And there have been many benefits of the empiric and the early use of Oseltamivir. Remember, there have been clinical trials which have supported Oseltamivir treatment, and this is particularly in the form of reduction of the lower respiratory tract complications, unnecessary use of antibiotics, and hospitalization. Also, the occurrence and the severity of pneumonia is also reduced, okay, because you are using it early. And remember, in 2009, when there was a pandemic of H1N1, earlier initiation of Oseltamivir after the symptom onset reduced the occurrence and the severity of pneumonia, and it shortened hospitalization. Remember, some of our colleagues will ask, see, many times patients do not come to us on day or 1 or 2. They come on day 4, 5, 6. Okay, what do? We know that it's flu. Probably they come with a throat swab report showing flu. Remember, even if you give Oseltamivir after 4 or 5 days, even if the child has started getting low respiratory involvement, please use Oseltamivir, because it has been found that even if you use Oseltamivir little late, okay, in the course of illness, it does reduce mortality and it does reduce viral transmission, because I told you that replication and the transmission of virus continues for 7 days, and that's why you are fully justified in giving it even when the child comes to you little late. Okay. And WHO also has recommended strongly. WHO says that you can give Oseltamivir empirically, and the treatment should be started as soon as possible, need not wait for lab confirmation. And even if the lab test is negative for H1N1, it does not exclude the diagnosis in all the patients. And that's why you have to give it early. And if the higher risk individuals have been exposed to a patient in influenza, please consider presumptive treatment with Oseltamivir. Okay. And that's why the government of India has suggested early empiric therapy and monitoring with Oseltamivir. Okay. And they have recommended the use even for adults, where the test for influenza has come positive and the adult has community acquired pneumonia, and particularly in patients who are hospitalized, who are positive for influenza virus, and treatment within 2 days of symptom onset or hospitalization has been found to result in the best outcomes. So my dear friends, remember that influenza has started attacking us in an unusual pattern at unseasonal timings. Okay. And majority of these cases are H3N2 and H1N1 and influenza B. You have to diagnose it properly. Either you have to have an educated guess, or you have to diagnose it by a nasopharyngeal swab. And early treatment can prevent flu complications. You all know that early treatment also, reduces the duration of the illness by 1 or 2 days. And the empiric use of Oseltamivir is also known to reduce the lower respiratory complications, hospitalization, and antibiotic use. And WHO, American Thoracic Society, Ministry of Health and Family Welfare, all of them, they recommend the empiric use of Oseltamivir. So my dear friends, please remember that influenza is a disease which, is not that benign. It is changing its structure. Once in a while, it produces problems like pandemics, but otherwise every year it is showing its own different pictures. And whenever you find a child coming with high fever, with chills, headache, and weakness and myalgia, please do not hesitate to give the antivirals. And I always say that flu, the spelling is FLU, and it ends with U. And that's why this virus if it is to be controlled, then you have to be really, really aware of various presentations. You have to aware about vaccines also. And one of my friends wants to know certain things about, vaccination. So I will give a bit of my time to the flu vaccine. Remember that all these various viruses, particularly H1N1, H3N2, and two lineages of type B, they have been brought together and a quadrivalent vaccine has been prepared. That is called as quadrivalent influenza vaccine. It is an inactivated vaccine. And as I told you, it shows changes every year. And that's why vaccine composition also changes every year. As I told you, during the season of monsoon, there is always rise in the number of cases of influenza. And that's why it is wise to give this vaccine 1 or 2 months before the actual season of influenza. And that's why if we are contemplating influenza in the months of June and July and August and September, it is always prudent and wise to give it in April and May. So this is the time when you should, please tell the parents that, see, this is the time when you have to give the flu vaccine so that the children do not get sick when it is monsoon. In some parts of our country, like Jammu and Kashmir and Tamil Nadu, the monsoon comes on the latter part of the year, somewhere in December. And that's why at that time, you can give the vaccine in the months of October or November. All the information about the strains which attack people during this particular season of monsoon is sent to the different reference laboratories. And from there, it goes to the WHO, and WHO gives a recommendation for the strains of influenza virus to be added to the vaccine for the next year. This is done at 2 times. Okay. So the southern hemisphere strains, usually the ones in the monsoon season, and the northern hemisphere strains. Okay. So there are different strains, and twice in a year, this information is given to the WHO through the laboratories. And that's why in a year, this vaccine is brought 2 times. Okay. So different companies which manufacture influenza vaccine bring the vaccine 2 times, and these strains are most of the times a bit different. Okay. Many times they are same, but sometimes there are some changes. Okay. Maybe the strain may change from California. It may become, Sydney or something like that. Okay. So only there is a change in one of the strains sometimes. Sometimes maybe more than 1 or 2 strains might change. For us, we have to remember, whatever is this vaccine available in the market, you have to give it to the child. What is the schedule? The schedule is that in the first year of life, you have to give 2 injections. The first injection is after completion of the 6 months of the baby, and the second one is after 7-month completion. That means at an interval of 1 month. Okay. So please remember to give 2 shots in the first year of life. Later on, from the second year of this child, you have to give annually 1 injection of flu vaccine. Most of our colleagues are learned, and I hope they are aware of the different schedules. However, there are many times, some queries from our colleagues. If at all this child has received some northern hemisphere vaccine in the month of October, and he comes to us, in the month of May, what to do, whether we should repeat, and so on and so forth. Just remember a broad principle that when you give 2 shots in the first year of life, or maybe if the child did not come in the first year and came directly after 3 or 4 years, when the child receives 2 pricks at an interval of 1 month, it is priming and boosting. The first one is a primer, and the effect of the first one is boosted by the second one. And that's why this child is now fully protected for next year. So when he comes next year, you need not again prime this child. So you can very well give a single dose. Okay. So even if this child who took the first set of 2 pricks in the first year of life did not come for the next 2 or 3 years and comes directly at the end of 3 years, you are fully justified in giving only a single dose because he has been primed earlier. The immune system has been primed. Okay. And some of these facts about the vaccine are always discussed in our different fora. But you just remember that priming and boosting is something which is very, very important. One of our listeners also wants to know the dose of Fluvair, that is Oseltamivir. I already elaborated that in adults, the therapeutic dose is 75 mg twice daily, while the prophylactic dose in adults is only once daily. Okay. And then in general, as a pediatrician, the dose is 3 mg per kg. And if at all the child is under the age of 1 year, you can always use it in the syrup form. And the syrup contains 12 milligrams in 1 ml. So if at all you have to give 30 milligrams, then please see that you give 12.5, and 5. That's total of 30 milligrams, and that comes to 2.5 ml to be given to this particular child. And all these doses for the therapeutic purposes are given in 2 divided doses, and for prophylactic purposes are given as a single dose. Okay. So with that, a lot of information about flu, Oseltamivir, flu vaccine has been imparted from my side to you. And in case if you have any queries, feel free to put your questions on the chat box. Otherwise, Dr. Manohar, please let me know if you have any other queries which you would like me to clarify.
No, sir. Whatever queries are there, I already shared with you. And
Thank you.
I want to thank you very much, sir, for making these subjects such a explain in such a simplified manner. And I hope today's attendees must appreciate this gesture from your end, sir. Thank you for being on the platform for the flu management and guiding our audience for the management as well as the current challenges option also, sir. So on behalf of Hetero Healthcare, I would like to once again thank you as well as all the attendees who attended this webinar today. Looking forward for your suggestions also. Thank you so much, sir.
Thank you. Thank you.